Brothers and sisters, Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome to a new episode of Health. When somebody is told that he or she would have an operation, of course, they would start to worry about it. And a big part of the worry is a concern about the anesthesia. Many patients would not refuse to do an operation or go through a surgery because of the fear of anesthesia, and many of the bad repetition or the gossips that the anesthesia is unsafe might cause the problem after the surgery or during the surgery. With us today is Professor Amr Muntasir, Professor of Anesthesiology. Welcome, sir.
Welcome, Ahmad.
Actually, people would have this fear, maybe even more than doing the surgery itself. They would go and tell you what kind of anesthesia I'm getting, which type of anesthesia, what would happen to me. Actually, the problem with the anesthesia has been taking a big space of the worries of our patients. Why is that?
The problem is patients do not know enough knowledge about anesthesia. So if you walk into a dark room, you're afraid. If the room is illuminated, your fear is gone. Same with anesthesia. They don't know anything about it. It's dark to them, so they are afraid. If they got enough explanation and knowledge about it, the fear is gone. So it's a problem of conveying the message and the information, the proper information to our patients that will relieve their anxieties and fears.
Yes, and actually the problem of not knowing the real or the exact details of the anesthesia is not the problems only for the doctors. I'm afraid to say it's also sometimes the problem for the surgeons themselves. They cannot conduct. Yes, this is actually true.
Yeah, this is a bit embarrassing because as colleagues of our profession, they should have enough knowledge, at least the broad idea about the different types of anesthetics and how they interact with their procedures that will make them comfortable. And that's why usually surgeons and anesthesiologists work in teams. They get to know each other, they get to know the way they are doing things, and then the procedure is safer. It's like the football team, for instance. Sure. You cannot have different players from different clubs coming and playing together. You have to get them together, train them together, and then they will be a harmonious team.
Exactly.
And they will perform better.
One of the images of anesthesia which might be imprinted in the minds of many people come from the old pictures or maybe even the comic book where the anesthesiologist is doing what he's doing is striking the head of the patient, or maybe putting some...
We can go to the monitor. Here is a picture from the end of the 19th century when people were not giving anything to perform the surgery. Here they are removing something from the foot of this poor guy without any anesthetic at all. They used to give the patient alcoholic drinks to get them drowsy, and then they do the surgery. Sometimes they put ice to numb the site of the surgery and do it. And then when they discovered anesthetic, it was a bit primitive, as we see in the next picture, where the anesthesiologist is standing on the head of the operating table, and it's pouring the liquid anesthetic on what we call the Schimmelbusch mask, which is a bit of gauze that used to collect the anesthetic liquid and let it evaporate on the face of the patients. That was the primitive way of doing things, or at the beginning of giving anesthetics. Nowadays, the operating room, as we see in the following pictures, like a cockpit with everything monitored and everything is calculated exactly to enable the surgeon to do his surgery and the patient to pass through it in a safe way.
Yes, this all aims to give good or conduct a very good anesthesia with the safety measures.
Sure.
I mean, the safety of the anesthesia, to assure our patients and to make them aware of the safety nowadays of the anesthesia, passing all through the stages of, let's say, the primitive anesthesia, all the way to the high-tech anesthesia. The safety of anesthesia, what does it depend upon?
The thing is, The dictionary definition of safety is freedom from danger, risk, or injury. And if we look at this, the following pictures where there is a patient being cut by a knife with the surgeon's hands, and in the background, the anesthesia machine or the anesthetic vaporizers. The three of them are dangerous. You have a sick patient, you have a surgeon cutting through his tissues with a knife, and handling very dangerous medications. If you give them too much, they will pop. So it's actually sort of an ironic thing that we provide safety in a very unsafe environment. But this is not to make people afraid, because nowadays, in the 21st century, the people's expectation is that there is no anesthesia associated with nearly zero mortality and morbidity. We see the components of perioperative mortality. They analyze statistically the contribution of surgery, the sickness or the disease of the patient, anesthesia, to the overall mortality rate, and they found that disease itself contributes to mortality by a ratio of 1 to 600. The surgery, 1 to 300. Anesthesia is the safest of the triad. It's 1 in 200,000 now.
200,000.
So it's about the safest thing on earth now is anesthesia.
It's the surgeon to be blamed then.
It's actually not the surgeon. It is because the surgeon actually is treating a disease, a pathology. So the pathology itself is the most dangerous.
But that's why it's comforting for our viewers and our patients, because many of them would be relieved to know that anesthesia is the least to cause the problems during the surgery time.
Provided that we will look now at the components of the anesthetic safety or surgery, you have a pyramid. The first pillar is the patient, and the patient is obviously not healthy. That's why he's having a surgery. And now this patient has to be optimized, so to speak, for the procedure. You have to assess him, you have to consider what he's going to have, the surgery itself.
Properly prepare the patient for the
surgery. And then you have the surgeon and the surgery itself.
Yes.
The surgeon has to be skilled. If the surgeon is not trained well, he's going to do a bad surgery, and that would be bad.
Of course.
So that's another component. And you have the anesthesiologist as well. The anesthesiologist has to be very well trained, very well informed about the modern methods of anesthesia, the new drugs, the new monitors. And then you have the medications that you're giving to the patients. Because of the many advances in the pharmaceutical industry, you have now very safe drugs that we call them the smart drugs, like the smart bombs that we see on television. They go to the specific site in the body, perform their function, and get metabolized and disappear from the body in a few minutes. You have also the equipment and monitoring. You cannot ask an anesthesiologist to give you a safe anesthetic without the modern anesthesia machines, without the modern medication, without the
What are the main things that these monitors do?
They actually measure everything that goes into the patient and everything that comes out of the patient. They measure the respiration of the patients, how much oxygen he is getting, how much carbon dioxide he is producing. They measure the oxygenation of the blood. They measure the function of the heart. They measure the function of respiration. Everything is tightly controlled. You can manipulate the heart and lung or the various bodily functions within a range. Sometimes in order to decrease the bleeding, for instance, if you're working on a very vascular field, the surgeon asks you to lower the blood pressure. So you lower the blood pressure in order to let the surgeon perform the surgery safely without losing much blood.
You can control that.
You can control that. And above all is the system and workplace. The whole hospital and the whole healthcare system has to be properly organized so that every individual working or passing through this as a patient through the healthcare system is, so to speak, passes smoothly. So the system has to be very well organized. People has to be satisfied with their salaries, satisfied with their level of education, satisfied with the work environment, having all the medications that they want, having all the equipment that they want to. I'm sure you as a surgeons are working with many magnificent new technologies in draining the bone, in having new cements to fix the broken bones, in manipulating the spinal cord or the brain or the heart. with many new tools that makes our job more precise and more safe.
Yes. So it has to be a continuum or a union between all these elements.
Of course.
It should not be just the anesthesiologist on his own. It's not the surgeon on his own. It has to be everybody working together.
Sure.
Everybody knows what's going on the other side. Again, the surgeon, I have to know what the anesthesiologist is doing,
sure.
and on the opposite side, yes.
Unfortunately, the media conveys the wrong message. You find that a kid dies doing a tonsillectomy and the medical team escaped. This is obviously done in a bad place, like a small flat in a building which is not having any safety measures or any safety standards. So,
exactly,
and then they blame the whole specialty of anesthesia for it.
That's true. Actually, it has to be everything working right so that we can get a good result at the end. Some people would worry about when they wake up after surgery, what time would they regain their consciousness?
The thing is, this has got a historical background because at the dawn of the specialty of anesthesia, the anesthetics used like ether used to hang around in the body for quite a long time, and the patient would vomit and be drowsy for hours after the procedure. But nowadays, with as I said, the smart medications that we have, the patient is unconscious for the period of the surgery, and that's it. They wake up very clear-headed, very fast following surgery. So that drunkenness is very limited.
Yes. We'll be going to a break, brothers and sisters. We'll be coming back shortly, so please don't go away. We'll be shortly back. Assalamu alaikum wa rahmatullah. Brothers and sisters, Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back. We're still talking about anesthesia and its safety. With us is Professor Amr Muntasir, Professor of Anesthesiology. Welcome back, sir. And thank you very much for alleviating the morale of our patients in making them more safe. I mean, feeling more safe when they're going through the anesthesia procedure.
Thank you for giving me the opportunity. It helped us in providing our anesthetics to our patients because we have to establish rapport with them and they have to trust us. Without the enough knowledge about what we're doing, they don't trust us enough. They only listen to what they hear, unfortunately, in a bad way in the media.
Yes. The choice of the type of anesthesia. Some patients would come to me and ask for a regional anesthesia or a spinal anesthesia. And some of them would be afraid to do this and would ask for a general anesthesia. And actually, when you talk to the patient and see what's his knowledge and what's her knowledge about this, they seem to be having a very confused idea about, but fix and believe that this type of anesthesia out of nowhere is the proper type for them. Actually, we leave this to the anesthesiologist. So which type and what kind of anesthesia, your choice, how would you build this decision?
The thing is, generally we have two broad types of anesthetics. The general anesthetic, where the patient loses consciousness altogether, and the regional. Under each big category, there are subtypes. For the general, for instance, you can have it by inhalation, where the patient is connected to the anesthesia machine, and we evaporate in a very calculated manner our inhaled anesthetics that go through the ventilatory system and get absorbed from the lungs and reach the brain and various organs of the body and put the patients to sleep.
Yes.
You can do the general also with continuous intravenous injections. We have also intravenous anesthetics or combination of medications that you can give intravenously. Nowadays with computer-controlled syringe pumps and infusion pumps that will also reach the target organs in the brain and heart and to put the patient to sleep. For the regional, we have so many types, the spinal for and the epidural for the lower half of the body and the abdomen, and the specific nerve blocks where you can block the specific nerve that goes to the specific area where the surgery is performed.
Yes.
As far as the selection, you tailor your anesthetic to both, as we said, the triad, the patient, the anesthesiologist, and the surgeon. You have to tailor the anesthetic so that the surgeon to enable the surgeon to perform the surgery on that particular patient. Suppose you're doing, let's say, for instance, cataract surgery in a man or a woman who's 80 or 85-year-old, who's obviously having compromised heart and lung and various bodily functions. The most logical way is to give a local anesthetic around the eye, paralyze the muscles around the eye and the sensory innervation of the eye, and the surgeon will do the surgery in a safe way. And also you have to consider the patient's requirements. Some patients are afraid to lose consciousness. They insist that they have to be conscious. They have to have full control of the brain during the procedure. So if the patient asks for that, the obvious choice is a regional or a specific nerve block.
Yes. Some patients even have the fear of going asleep because they have the concept that when they wake up, they would tell all the secrets. And all, even though I've never seen during my practice anybody telling me what happened.
This is actually done by the Secret Service in different parts of the world, where they give a sub-anesthetic doses to the victim, so to speak, so that they remove the control of the cortex, the outer area of the brain, all over the various centers of the brain, so the victim or the captured starts to tell his secrets. That doesn't happen in real life world unless it's done specifically, as we said, in spy interrogations.
Some people would worry about when they wake up after surgery, what time would they regain their consciousness? What time would they be able to pray? You know, Allah says, وَلَا تَقْرَبُوا الصَّلَاةَ وَأَنْتُمْ سُكَارَى. Do not approach praying while you're drunken. Actually, Muslims would not have drinks or alcoholic drinks that would make them drunken, but anesthesia in a way makes a person...
The thing is, it's also, this has got a historical background, because at the dawn of the speciality of anesthesia, the anesthetics used, like ether, used to hang around in the body for quite a long time, and the patient would vomit and be drowsy for hours after the procedure. But nowadays, with the, as I said, the smart medications that we have, the patient is unconscious for the period of the surgery, and that's it. They wake up very clear-headed, very fast following surgery. So that drunkenness is very limited.
Yes. How about the other question that's very common? What time, when a patient gets a general anesthesia, what time can he start drinking and eating?
It depends on the anesthetic and the surgery as well, because if you're working on the bowel of the patient, obviously that particular patient is not going to eat or drink for a day or two after surgery, and he get his daily requirements through infusions. But if you're doing, say, as I said, a cataract surgery under local, you can eat or drink immediately after the end of the procedure.
Yes.
If you're doing surgery on a bone, 2 to 3 hours after surgery would be sufficient for his normal physiology to get back to its original state, and he can start. We do that slowly, obviously, because some of the painkillers makes the patient nauseous, and also not all the patients are the same. Females get nauseous more, smokers get nauseous more, so you have to, obese patients get nauseous more than lean patients, so you have to tailor your instructions to that particular patient doing that particular surgery.
Yes. Shifting to the regional anesthesia, and there's a wide variety of choices
nowadays.
Yes.
In my opinion, regional is safe, or sometimes you combine a light general with a regional so that you get the benefits of both. It was not common to do regional anesthetics in the last decades, for instance, because the success rate of giving a particular nerve block was about 50 to 60%. So you have a 50 to 40% chance of not doing it properly.
Failure.
But nowadays we have technology is available to us where we use ultrasound to locate the nerve and to see it, and to see the needle going through the tissues and inject the exact amount around the nerve, and you can see it live. The nerve is bathed in a local anesthetic.
In fact, actually, we have what I can call your friend. I see him with you everywhere you go, and I saw you doing a great job with it. I mean, many of my patients that you've been doing, and our patients, you've been putting the patient in anesthesia, just the region that we're working through, or
And even for, if you do say a joint, knee or hip replacement, even under general, you can
Yes.
locate the nerve going through the lower limb and inject a big amount of local anesthetic. That, in that way, the patient would not feel any pain for a day or two after surgery. And this is one of the major worries for our patients, that they are afraid that they are going to feel pain after surgery. If that worry is alleviated, half of their problem is solved.
so. Please tell me, what does this machine do?
This machine is an ultrasound machine like the one used by our colleagues in the radiology department to,
Yes.
to examine various parts of the body. Since the technology got more and more better, nowadays we can use it. Even the inexperienced physicians like ourselves, we're
Yes.
not radiologists, but we can handle ultrasound machines
Exactly.
to look upon the nerve that we need to anesthetize. And obviously you have to be knowledgeable in the anatomy of that particular region, so that you know what you're seeing on the monitor, and you locate the nerve, watch it on the monitor, introduce the needle under direct vision.
Do you have some pictures here?
We can see on the monitor, the first picture is the picture of the femoral nerve, the nerve supplying the thigh of the patient.
Yes.
And you see the artery on the left side of the screen and the nerve right next to it.
Yes.
The second picture shows us the needle, which is that line staying on top of the nerve.
Yes.
And the third picture, we injected the local anesthetic and the nerve is bathed, as we see in the local anesthetic, and that gives us 100% success rate with the regional anesthetic.
Yes. Yes, that's great. I mean, if you can just anesthetize the region you're working on, and your patient can still, I mean, is awake or she's awake and they're talking to you, and maybe this would add to the safety of the sense of comfort to the patient.
Of course. The more you see in any specialty of medicine, the more you see, the better the results are. And we're fortunate enough that we live nowadays in the wonders of technology and
Yes.
the computer sciences that gives us our toys that makes our life easier.
And makes the patient's
and
life
safer,
easier
of
and
course,
safer,
and safer,
inshallah.
of course.
Professor Amr Muntasir, Professor of Anesthesiology, thank you very much for being with us here and elaborating many of the hidden parts of the world of anesthesia. I'm sure our patients now are feeling better about anesthesia, getting in peace with it, and their fears about it are much, much less. Thank you very much, sir.
Thank you for giving me the
Brothers
opportunity.
and sisters, yes. Brothers and sisters, thank you very much for joining us today. Until then, Assalamu alaikum wa rahmatullahi wa barakatuh.